Okay, so today we're going to talk about tips and tricks for surgical guides. First and foremost, I want to thank everybody for being here, and I want to remind everybody that we have a very active Instagram page and Facebook page. If you can just hit the like button and share our Instagram and social media platforms with your colleagues and friends. We also want to thank our sponsors, Colteen, Oral Arts, Garrison Dental, and Cavo Kerr for their continued support. I want everybody to know that today we will be offering a 1.0 free CE credit will be provided for this webinar. And I will show you just in a minute how would you be able to achieve those credits, achieve that credit, I'm sorry. So the first thing that we want you to do is that we want you to visit our webpage, www.romerodentalseminars.com. And once you are in our webpage, go ahead and click this link that says webinars, and you will find 3 additional links there. Link number 1 will say live webinars, and in that live webinar link, you will find future webinars and dates so that you can go ahead and subscribe. Our second link is our on-demand link where you will find every recording of our previous webinars. You'll have the 2020 webinar series and the 2021 webinar series. Please don't forget that we are only offering CE credits for our 2021 on-demand or live events. And finally, you will find our link to our CE quizzes where you will go in and you will find a list of webinars. Please go ahead and download the PDF file, complete it in your computer, and then email it to us at romerodentalseminars@gmail.com. Another way that you can find our videos is just visiting our YouTube channel. If you use any browser and just hit Romero Dental Seminars in YouTube, you will find our YouTube channel and all our videos are displayed there. So our objectives for today's presentation are: the first one is to understand the different surgical guides and options available today, how to fabricate and use a simple clear guide for a single implant, how to convert a temporary fixed dental prosthesis into a surgical guide, understand how to use a patient's existing denture to fabricate a guide, and learn how to effectively communicate with the lab for a fully guided surgical protocol. So let's get started with our tip and trick number 1. Let's look at the clear vacuum form tray. So as you know, if you've been part of our webinars before, our webinars are normally very clinical. So I'm going to share with you today this first case. And what I want you to see here is, the way that we received our patient. You can see that this patient had lost tooth number 10, which is a lateral incisor. A previous dentist had bonded the actual crown of tooth number 10 to the adjacent tooth number 8 and tooth number 9 and tooth number 11. You can see it from the facial view on the left-hand side and from the lingual view on the right-hand side. Patient was a smoker, and you can see some of the nicotine obviously staining this composite. This composite was there maybe for a little bit over a year when we received the patient in our dental chair. So the first thing that we did for this patient obviously was to remove that temporary bonded prosthesis and remove all the excess resin that was used to bond to the neighboring teeth. And then we're just going to start evaluating the case. And, as we all know, there's a couple of things that we need to evaluate when we are, having a patient, and we're going to make a decision based out of or based on can we or can we not place an implant for this patient to restore that site. And as we all know, there's other options as well for restoring that site. But it is my understanding and the way that I see dentistry that in today's world, with the materials and the techniques that we have, the first option or the best option at this point would be placing a dental implant in this site. So in order for us to be able to evaluate the site and see if the implant is the right option, or is it a possibility, or at least when the patient sits in our chair for the first time, is just to look at the defect or the edentulous side. And as you can see on photo on the left hand side and the photo on the right hand side, here the patient presented with a fairly large bony defect in that site, and we were thinking that maybe the buccolingual width of the bone was not going to be ideal for us to be able to place an implant. So the first thing that we do is that we're going to look at a periapical radiograph. Patient presented in that site a residual cyst, as you can see here on my X-ray on the left. It was a good, fairly good sized cyst there. So we knew immediately that the first thing that we were going to do is, access the site and then remove the cyst and graft this area. So right there, then we knew that our first option was not going to be to place an implant immediately after we access the site. So we were going to have a 2-stage or maybe even a 3-stage surgery. We were going to first graft, then place the implant in our second stage, and then have a third stage where we're going to go ahead and restore that implant. So this is how we found the site. This is the axis the day of surgery, and we were able to remove completely the cyst, the residual cyst that we found in that area, clean that area very nicely, and then obviously go ahead and perform a graft on the site. Before we went ahead and performed a graft on the site, we did use a pilot drill on the site just so that we can expand the bone. Remember that we had this buccolingual defect, so we wanted to expand a little bit of that bone on that site before we grafted, so that not only we were going to get, we were going to fill that the height area or the apical area of our lesion, but we were going to be able to achieve a little bit of bone width during that first surgical procedure. So that's what you're seeing there. We're using a pilot drill on the left-hand side, and you can see that that pilot drill goes right into that area where we are lacking actually bony tissue due to the large cyst that the patient presented. Once we do that, we're going to go ahead and we're going to use some site dilators. And in this particular case, I used a multiple different width. I think I went all the way up to either 4.0 or 5.0 with a site dilator, just in order for me, again, to push that buccal bone a little bit more facial. These are just an example of site dilators. There's many out there in the market. And these are just the ones that I use, but there are many others in the market. So if you use a different brand, I mean, that's perfectly or totally fine. The idea of these site locators, again, is just to kind of expand or also densify the bone in that site prior to us, placing an implant, so that we can definitely, expand and achieve a little more buccolingual width for that site. And you can see it here again. Now, from an occlusal standpoint, we were able to get that dilator in, expand the bone, more than what we wanted. Always, you have to understand that you're going to have a 20 to 30 degree resorption of that graft that you're going to place on that area. So we want to make sure that we end up with a good amount of graft material there once we're done with the surgery, because we know we're going to get a little bit of collapse of that tissue or the graft on the site. So here you go. We're using our last dilator. Then we're going to go ahead and remeasure, and you can see that on the right hand side, you can see now that we have been able to push that little bit of coronal bone left, kind of like to the 7 millimeter width. And now we're going to go ahead and fill that site with bone. So we're adding our bone, and we're using here demineralized freeze-dried bone, and we're going to have a mixture of 70-30 mineralized and demineralized bone. We're going to fill that first, the cavity, obviously the area where we were missing, where we had that the cyst, and then we're going to go ahead and just fill the entire area. Our goal is to just fill the area, get into the socket, have new bone in that area, achieve a little bit of more buccolingual width of the site, and then we're going to go ahead and place a membrane. We're going to cover the graft to avoid any infiltration of tissue in the site. There's many ways that you can secure your membrane in this site. You can use titanium tacks. I like using sutures. It's a very simple technique, and personally, again, I like to try to maintain my surgical procedures as simple as possible. And I want everybody out there to know as well that I do some surgery in my practice, and I place many of my implants, but I do refer a good number of my patients as well outside when my surgical procedures or the surgical procedures that are needed by the patient are more complex. So I try to stay in my lane. I try to stay with the things that I find that I feel comfortable with, and that I know that are going to be successful in my hands. But not every case can be successful in my hands, and I do want to make that clear. So once we suture the area, again, you want to have no tension in your sutures. We're going to give our patient an excess retainer with a little lateral incisor added to it, so that he can have something to cover the space. And then we're going to see the patient back in maybe 2 to 3 weeks. We're going to just kind of see the site. I want to show you this x-ray. This x-ray was obtained right after the surgical procedure, so that you can see here the preoperative x-ray on the left hand side, the surgical side right in the center. But look at the x-ray on the right hand side. Now you can see that we were able to fill the area substantially with our graft material. And that's what an x-ray should look like right after a procedure, where you're grafting a site that looks like the site that I'm grafting for my patient here. And now you can see we've been able to, this is now maybe 10 to 11 days after the surgical procedure was performed. And you can see that we have now an initial state of healing. You can see that we were able to achieve primary closure. And you can see now that there's good healing going on. So we're just going to go ahead and remove the sutures and just send the patient home. We're going to have him use his Essex. That's what we're going to use. Something that we don't want any pressure on the site. Obviously, we don't want. I would not like to use a flipper or something like that on this side. Now, nothing wrong with using something like that. That may be something that you would like to use. But personally, again, my goal is to have the least amount of pressure in the site right after my surgical procedure, because I want to try to keep that site without any disturbance. So this is now maybe I would say 4 months later. You can see that there's some recession on the side. This is how the patient presented with his anterior teeth. He was missing a couple of other teeth in his mouth, but we were little by little kind of going through different areas in order for us to improve some of these areas for him. And obviously, one of the areas that he wanted to for us to tackle initially was going to be this lateral incisor, because, as you may think, it has a lot to do with the aesthetic aspect of his smile. So, obviously, you can tell that there are some failing restorations on both 8 and 9. So we're going to go ahead, before we even plan our implant location for site number 7, we're going to go ahead and restore to the correct mesial distal width both 8 and 9. And what you're seeing on the right hand side is both of my composites completed on teeth 8 and 9. And now I do have the correct mesial distal width for tooth number 10. So now I'm ready to go ahead and wax that side up. And you will see it here on my next slide. There is the completed composite. You can see here where I have added a denture tooth to the site of number 10. And using this model, using this cast, where I have been able to wax up this tooth, now I'm going to go ahead and fabricate a suck down. And again, my first tip is, how can you use a suck down in order for you to place an implant? And this is a very easy technique. This is a very something that you can do directly in your office, and and it's very predictable if you use it the right way. Again, what this suck down is giving you now is giving you the facial aspect of tooth number 10, is giving you the lingual aspect of tooth number 10, of the future tooth number 10. So now you can figure out, okay, if I need to place an implant on this side, where would be the ideal implant location? And obviously, ideally, you want to be slightly lingual to the facial aspect of the tooth, so that your access hole is actually on the lingual. And if you decide to use a screw retained prosthesis, then your screw is going to be on the lingual side. Now, in many cases, depending on the location of the bone, depending obviously on the buccal lingual width, you're going to have to play with the location of the implant and where that access hole may be. But this guide, this clear matrix, and even today that I use a lot of 3D printed guides, and I'll show you a case at the end on how do I do that today. This is still a valuable tool for me because I can still use this even if I'm using a 3D printed guide. I can use this to kind of see, okay, what would the location, what would the crown look like once my implant is in that site? What would that restoration look like in this site with that implant in that location? So this is going to give you again that buccal lingual aspect of the actual tooth that would need to be replaced based out of your wax up, and that's what I'm doing here. So what I normally do is that for this clear matrix, I'm going to create an access hole on the lingual that is approximately 2 millimeters in diameter. So with that access on the lingual, that is what I'm going to be using for my pilot drill. So what you see on the left-hand side is me with the clear matrix in my patient's mouth, and I'm using now my pilot drill to go in and access that site through the lingual of my clear matrix. And once I do that with my pilot drill, the next thing that I'm going to do is I'm going to grab a paralleling pin and I'm going to put it in that initial osteotomy that I've created. The reason why I want to do that is to make sure that my implant is going to have an access that is going to be centered correctly within that clear matrix. So there's two things that you can do. First and foremost, I'm going to go ahead and look at the pin and I'm going to see, am I equal distance between the distal of the central incisor and the mesial of the canine? Then I grab that clear matrix and I put it right on top of that of the paralleling pin. The paralleling pin will come out literally through that little access hole that you created on the lingual. And now I want you to look at the facial aspect of that clear matrix and the lingual aspect of the clear matrix. And you're going to ask yourself, is this pin centered buccal lingually? So if you feel and you know that you're centered, you know that you're in the right position. And again, this is a really good technique for these single implant surgical procedures that you're going to be performing in your practice. And I know that the great majority of patients that you're going to have initially in your practice are going to need a single implant. So this single implant surgical technique or surgical stent is a really good, inexpensive, simplified way of doing it in your office. So you can see here, now that I have assured myself that I'm in the right location, I'm going to keep my hand steady and I'm going to go ahead and continue with my osteotomy and then finally deliver the implant in that implant site. In this particular case, I use a Zimmer implant, and you can see that I've placed the Zimmer implant and the implant carrier, the flat surface is placed towards the buccal. And this is just to keep an orientation. If you decide to use a stock abutment, this is going to become very, very important because your stock abutments, the facial aspect of your stock abutment are going to align correctly with the implant if you are using these flat surfaces and you're placing these flat surfaces to the facial aspect or the buccal aspect of your site. And on the right hand side, you can see now my healing abutment and my sutures that have been placed immediately after placement of this 3.7 diameter implant. And I think that my length was I think it was around 11.5, the length of the implant that I chose for this site. And here you can see the completed case. Now you can see patient had a low smile line, so that gingival defect or the recession that we had on that side was not even visible when the patient would smile. But I want you to see the biointegration, the way that we were able to match that lateral incisor to his contralateral incisor. And I want you to look at both 8 and 9 resin composites, the mesial distal width and the anatomy that we were able to achieve in our composite that you can see on this side view photo were ideal for this patient. And again, we're just putting this tooth back in and just giving him back his smile, which was his chief complaint before we started this case. So this will take us to our tip and trick number 2, which is using an existing fixed dental prosthesis as your surgical guide. And again, you are seeing here, this patient presented to the clinic. She had an existing zirconia fixed dental prosthesis that was giving her some issues, so that we had to remove. And what I did is I literally took an impression of the actual prosthesis and used that to make my temporary prosthesis. And that's what you're seeing here. So what you're seeing here is now I have these two abutment teeth, which is the premolar and the second molar, and I have this pontic area, which is the first molar. And what I'm going to do is that the day of surgery, I'm going to use this prosthesis, this temporary fixed dental prosthesis, as my surgical guide. Again, I'm just trying to share with you a little bit of tips and tricks of things that you can do in your office just to simplify certain dental procedures and go about performing your surgeries specifically today in relationship with implant dentistry. So there you are. You can see that directly into the patient's mouth. I'm going to use a number 4 round burr, high-speed round burr, and I'm going to go right in the center, and I'm going to make this little notch right in the center of that implant, slightly towards the lingual, just like you're seeing it, of the temporary, of that pontic, of that first molar, slightly towards the lingual. So my idea is I'm going to then retrieve this from the patient's mouth and use a lab burr to create a little bit wider than 2 millimeter hole right in the center of this fixed dental prosthesis. And what is my goal now? My goal is to use this little dental prosthesis, this little temporary, as my pilot, as my guide for my pilot drill. So I know that with this in the patient's mouth, I'm going to use my 2.0 pilot drill, and I'm going to create that initial osteotomy that is going to give me the exact direction that I'm going to need for the subsequent drilling sequence. And again, as you're seeing here, I'm going to use a combination of the Zimmer proprietary drills and the Versa drills. The Versa drills are drills that if you when used in reverse, you can now use or use them for osteodensification and to create what has known or has been published in the literature as the sinus bump, which is pushing a little bit of that bone from the walls of that socket into the sinus and creating or working on a internal sinus lift or sinus elevation in order for me to be able to place a longer implant than what I have been able to do if I did not use this technique. So what you see on the left-hand side is that pilot drill right in the center of the temporary, dead center with the temporary, and I went through that little hole access that you saw that I fabricated on the temporary. And what I'm going to do here is that I'm going to go all the way. I'm going to stay a little bit. You can see that I'm maybe a millimeter or 2 away from the sinus floor. Then I'm going to use the actual pilot drill going forward at 800 to 1200 RPM. This is the pilot drill that comes in the Versa drill kit. So with this drill, I'm now going to go all the way to the floor of the sinus, being careful that I don't penetrate or perforate that sinus. And for this, obviously, you do have to be very careful because now we just have this little thin wall there, but you will feel when the drill is actually touching that cortical plate on the sinus floor. And once you do that, then I'm going to start using all the Versa drills in reverse. And by using them in reverse, now I'm eliminating the actual cutting features of the drills and just creating this pushing of bone towards the side and apically, and I'm going to also densify using these drills. And these drills are specifically designed to do this procedure. So this is now the widest drill that I was able to use. This is the 4.0 within that Versa kit. And now you can see that I've been able to push bone within the sinus. And you can see that bone, you can see that new cortical, the way that I pushed this to create this shape for my implant. And you can see the actual bone that I was able to push from the sides, from this same side. This is autogenous bone that is being pushed apically within the sinus to cover the implant in that side. Now, do I use any type of allograft material for this? And the answer to that question is yes. Before I place my implant, I'm going to add a little bit of 70-30, a mixture of 70-30 mineralized and demineralized bone within the socket. And then while I'm placing the implant, and this is a 5.0 Zimmer implant, while I'm placing that implant, I'm going to push that bone into the sinus. And you can see this X-ray was obtained 6 months after the implant was placed when I was ready to restore the implant. And you can see that I've been able to push this more radio opaque material into the sinus, which is the grafted material that now is just have some return and created some osteoid tissue within the sinus and covering that apical aspect of the implant. So this is what we would call an internal sinus lift using the Versa drills to create this so-called sinus bump within the sinus and allow me to place a longer implant in that site. And here's my implant right after implant placement. You can see that I'm dead center between the molar and the premolar. And this is all following that initial surgical guide that I created using the actual fixed dental prosthesis temporary that I had fabricated for my patient. So again, another valuable tip that you can use in your practice. Here now we're ready 6 months later to place our final restorations. You can see that the location of the implant, we've added some composite to the implant just to take an impression of our emergence profile. And then we are ready to sit the actual custom healing abutment. We use an Atlantis abutment for this case, and we fabricated 3 individual zirconia crowns, which was better than having a 3-unit bridge for our patient there. Easier for our patient to clean that area, and obviously she can now floss and she can just enjoy, I would say, that new tooth. This is the actual little guide that is sent from Atlantis to us with our abutment, with our custom abutment, so that makes it a lot easier for us to sit this abutment into the patient's mouth. You just put this little guide that carries the actual abutment in the patient's mouth. It'll sit directly into the implant, and then you can have a screwdriver and go ahead and drive and torque that abutment in. What I like about this little guide that is actually sent by Atlantis is that it makes it a lot safer for us to sit this abutment in the patient's mouth, having less risk of dropping something in the patient's mouth. So having more control of the actual abutment. And then finally, we deliver all these 3 restorations. We cement them, and we're good to go. Patient is ready to enjoy that new tooth that is now held in place by an implant. And this will take us now to our third tip and trick of the day, which is the duplicated denture. So now we're going to talk about a patient that has no teeth, and we want to place, let's say, 2 mandibular implants in order for us to do a mandibular overdenture. And specifically, this is what this case is about. This patient had 6 implants placed by a different provider on the maxillary arch, and we were now getting ready to pick those, to expose, to do second stage on the maxillary implants, and then pick some locator abutments for her upper denture. But at the same time, she wanted to improve the stability of the lower denture. So we went ahead and placed 2 implants on the lower arch. But in order for us to place those 2 implants, we needed a guide. And what we're going to share with you today is, okay, how can I use an existing denture and fabricate a surgical guide to help me during the day of implant surgery for that mandibular arch. You can see here's a panoramic x-ray, and you can see where those implants were located in the maxillary arch. She had some Nobel implants placed there. So we're going to place now some Nobel implants on the mandibular arch. And here we are, we're planning these implants. We're looking at the site. We're looking at, where do we want them to be located? Just kind of give us an idea. We're looking at the bone width and height on site of implant number 22. And we have the same thing for the implant site on implant number 27. So we know, and you can see on the CBCT, that we have enough bone height and width for these implants. So this is a very straightforward case in regards to implant location, because there was a lot of bone in the patient's mandibular arch. So what we're going to do now is that we're going to now fabricate, we're going to make an impression of the intaglo surface of that denture and of the tooth side of the denture. And what you're seeing here is on the left-hand side, you can see this is the intaglo surface impression using PVS directly onto the patient's existing denture. Then we have the tooth side of the denture impression over here. And you can see that we've created some notches here where these two will connect. They will connect in a very specific way. And what we're going to do is that we're going to now mix some orthodontic clear acrylic, and we're going to place it within this aspect of the denture, the tooth side or the tooth impression of the denture. And then we're going to fully sit. We're going to make sure that this fully sits on top of it. We're going to lock them with some rubber bands, and we're going to allow that acrylic to set. And what you're going to end up having is a clear denture. Now, we wrote with one of my residents, we wrote and we published this manuscript that was published in Decisions in Dentistry in December of 2020. If you go and Google this simplified denture duplication technique in Decisions in Dentistry, you will be able to access this article and read it online for free. So if you want to know a little bit more about the specifics of the actual technique of how to make these impressions, how to use, what trays do you need to use and what material you can use to duplicate this denture in-house in your office, please go ahead and access this article, read it, and you will have the step-by-step guide on how we were able to fabricate this clear denture for our patient and use this clear denture to as our surgical guide for the day of implant placement. So you can see now we've created in the area of 22 and 27 these pilot surgical holes onto this clear denture. Not only that we create these surgical holes, but then we flatten, we remove from canine to canine, we make everything nice and flat. And this is going to just help us, giving us better visualization of the drills, of the pilot drill when we're making our bleeding points and when we're making our pilot drill within the bone, so that now we know exactly where we want to locate those implants. And again, for this particular case, where you saw that there was enough bone height and enough bone width, this is a good option, an easy to use surgical guide, easy to fabricate surgical guide that you can fabricate yourself in your office, and you don't have to send this to the lab to get duplicated and add more cost to your surgical procedure. So that's why I wanted to share with you this nice tip and trick today as well. So now you can see the denture is fully seated. It's going to sit in the patient's mouth because this denture, this is a duplicate of the actual denture the patient was wearing. So we know it's going to fully sit in the patient's mouth. So we just want to make sure that we try it in and it fully sits. And once we do that, we can go ahead and fabricate what I call bleeding points. And this is something that I always do and teach how to do before we are going to go and flap this patient. So we place our guide. We use a lancet type of blade, a drill, and we go in with that lancet drill and we just create some bleeding points directly onto the tissue. You can even go a couple of millimeters within the bone. Once now you remove this guide and now you create your incision and you open, you flap, you're going to see those bleeding points within the bone. And now you're able to just follow those drills. You can go ahead and place your guide again, going with the pilot drill, remove the guide, and now put your paralleling pills to make sure that you're nice and parallel in the intended location that you had planned initially in your CBCT. And that's what you're seeing here. So we did our bleeding points. We reflected our flap. We went ahead with the pilot drill, the 2.0 drill, one on each side. We removed the guide. We removed the drill, removed the guide, and then place our our paralleling pins and take some x-rays so that we can make sure that we are at the right, that we're parallel one to the other and that our locations are the ideal locations. And after that, we just go ahead and continue with the drills. You see that we're taking all these photos to make sure that these drills are nice and parallel, that they were within bone. And now we go ahead and place our fixtures. We're going to place 2 implants, 2 Nobel implants, one on each side. And then we're going to go ahead and suture, make some x-rays and suture. You can see the really good location of the implants where we wanted them. And at the same time, we can use now our surgical guides to verify not only the location of the implants, but to verify, meaning that they are located where we initially had planned where we wanted these implants. But most importantly, that we have a buccal and lingual flange for that denture when we want to pick up so that we're able to pick up our locator abutments when we are locator attachments when we're ready for that step, after the new denture fabrication. And here are the sutures, and then we just allow for that to heal. And my final tip and trick for the day is going to be the fully guided protocol. And I'm going to share a couple of things here that I think they're going to be very nice and valuable for you, because at the same time, they're not only going to allow you to use a external lab. For this particular case, we use Oral Arts Dental Laboratories to fabricate our guide. But I'm going to share with you how can you fabricate this guide in your own office at an affordable price, with an affordable investment. So I'm going to share with you this patient right here. You can see that patient had some aesthetic concerns, and he wanted to kind of manage that anterior, the midline diastema, try to locate his lateral incisors in a better position, specifically number 10. So there was going to be some ortho needed for this patient before we went ahead and placed any implants or did any restorative work. And you can see that the other reason was that we had lack of interocclusal space. So the ortho that was going to be performed for this patient was not only going to be, to correct, teeth that were not aligned correctly, but we were going to try to improve this area as well. So we went ahead and we referred the patient to the orthodontist, and the orthodontist that we referred the patient to decided to use Invisalign as the technique, or as the ortho technique. And you can see this is it took her like a year and a half, maybe 16 to 18 months to get the teeth where you can see them now. She was able to close that diastema. She was able to push the laterals and align them a lot better. She was able to give me a good mesial distal distance between the premolar and the molar, so that I can go ahead and place 2 implants there. And she was able to increase vertical dimension to actually improve that interocclusal space that I had on that site. So now I'm ready for my guide. And there's 2 ways that you can do this. Once you get your CBCT, way number 1, you can use your own dental lab. Now you got to make sure that the dental lab that you are using, that you're working with, actually has the technology to be able to fabricate, do this digital workflow for you. And again, the one that I recommend and the one that I use is Oral Arts Dental Laboratories in Alabama. That's the lab that I actually use to fabricate this guide that I'm going to share with you today. But at the same time, I'm going to share with you a way that you can do it in your own office and yourself. How would you train yourself or anybody in your staff to do this for you? But if you do it with a commercial lab, the good thing is that you will export your STL files. So you will export the DICOMs for the CBCT, and you can export your STL files of a scan of the area. You can actually make an impression of the area as well if you would like to, pour your cast, or just send the impression or the poured cast to the lab so that they can scan it for you. So if you don't have a scanner in your office, the lab can do that for you as well. They'll scan the site, they'll scan the area where the tooth is missing. In this particular case, we were at the site of the premolar and the molar. They can scan that for you, and then they can go ahead and wax it up for you as well. Now, the wax up can be done either on normally it's done, the lab will do it normally on the same software that they are using to fabricate their guides, and there are many softwares out there for that. So again, you can see here, the lab was able to receive the STL files, kind of choose, okay, this is where I think that these implants should be, and this is them making those decisions. But after they make those decisions, they're going to do their wax up, they're going to scan the models, they're going to then integrate the STL files of the models with the CBCT scan and your wax up. And now they're going to say, okay, this is where the teeth should go. This is where the implant should go for the teeth to be located there. Once they do that, what they're going to do is that they're going to give you a call, and they're going to remotely share with you their screen. And they're going to say, okay, Dr. X and X, do you like these implants in this location? Is there anything that you want me to modify? So now you have this conversation over the phone, and they will be able to guide you, and they will be able to tell you, and you will be able to tell them, yes, I want you to come a little bit more coronal. I want you to go a little bit more apical. I want you to modify the angulation of the implant. All these instructions, you can give them to them over the phone. You are looking at this live, and this is the way that I fabricated this guide with Oral Arts. And they'll make any changes that I am requesting over the phone, watching live their screen. And then right after that, they'll go ahead and they'll fabricate, my guide. And you can see that we're looking at one implant at a time. If there's any comments that I make, I write down my comments, and they will go ahead and proceed with, making the changes that I'm requesting. You can see that they send me all this full report. They will give me all this report with all these images, and then they will go ahead and print my guide and fabricate. They can even fabricate a custom healing abutments for you. So that's the way, that's one way of doing it. Another way of doing it, how can you do this in your office? How can you do this yourself? So I do this myself as well. I have some cases that I like fabricating my guides myself. And the way that you can do this, the way that I do it, that I have found that is very convenient, both financially and ease of use, is using Bluesky Plan 4, which is actually a free open software that anybody can go ahead and download directly from the internet. You just Google Bluesky Bio, and you will be able to download this. It's free to you in your computer, and all you have to do is you will have to purchase the exports, and they have multiple plans. Depending on the number of cases that you think that you're going to be doing in a year, you can go ahead and buy, I don't know, 15, 20, 100 exports. And what that enables you is that you can do your whole design in this software, and then you will be able to export your STL file within the computer. For that export, you would have to pay. The good thing is that they do have a free trial. So I think that you get maybe 2 free exports that you can do it, just to kind of train yourself. But the other good thing about this system is that not only that it's free, that you can use it and you can download it. You don't have to purchase, you don't have to update it, you don't have to have any license for this product. You just get it and download it into your computer. But the other benefit is that if, let's say that you have a case and you have this same patient and you want to make multiple guides, you want to make a pilot drill guide, you want to make a fully depth guide, whatever you want to do for this patient, you will only be charged one export per patient. So if you're paying for an export, let's say, I don't know, 12 or whatever dollars they charge for an export, or 20 something dollars they charge for an export, then you will pay one time for that patient and you can do multiple exports for that same patient. The only time that you will be billed again is that if you start a new case with them. And again, they have a lot of tutorials in YouTube that you can watch very, very easily, and you will start fabricating your guys in no time if you decide to do it this way. So for this particular case, I'm going to share, this is a different case of another patient of mine, and I'm going to share with you how I went about and fabricated myself the guide for this patient. So you can see I've selected the site, this site number 30. You can see the quantity of bone, height, width, everything is there. Now what I'm going to do is I'm going to import my STL file with the wax up. I like using a different software, which is a free software as well, called Mesh Mixer, to fabricate my wax ups. But you can use, they have a digital library. Bluesky Bio has the same digital library, tooth library that I use, incorporated in their software. So you can use their own software to do your wax ups, and that way you don't have to use a different software to fabricate your wax up. But that's only totally up to you. This particular case, I use Mesh Mixer for my wax up, and I imported my wax up into the software, and then combined my wax up with the DICOM file. As you can see here, my wax up now is attached to the mandible. It's actually located in the exact same position as the actual teeth on the patient's mouth. So I know that this is the right position for tooth number 30 within my wax up. And once I do that, then you can go ahead and fabricate your guide. And again, there's a lot of softwares out there. I'm not going to go into the details, but just wanted to give you the information that this is something that you can do yourself. You don't have to pay a lab to do this for you. And I do this for my simple cases. If I have cases where I feel that I'm going to place, I don't know, 6 implants, and I'm going to need a bone reduction guide and things like that, I rather do that with a commercial lab. There's a lot of dentists out there that do them themselves, and that's perfectly okay. But this is totally up to you, what you want to do in-house and what you want to go ahead and send out to a commercial lab. So once you have your guide, you have your STL file, this is what you print. And this is the actual printer that I have, that I use personally. This is a very inexpensive printer. It's less than $300. This is Anycubic Photon S printer. And this is the one that I use, a very simplified, very simple printer, small printer. It's not bulky. It's very easy to fit in anywhere in your practice. And this is the one that I use. And obviously you have to purchase a surgical 3D resin to be able to print your surgical guide. Now, the most important thing that you need to have is this. I use this same resin that you're seeing here on my screen, the Sprint Ray resin, but I don't use their 3D printer because obviously it's a lot more expensive than the one that I use. And again, the one that I use works very, very well for what I want to try to achieve. And I'll show you my guides in a minute. So what you really need to have is this settings. These settings that I have here on my right-hand side of the screen are very, very important, because these are the settings that you need in order for you to be able to use this resin within this printer. The settings that the printer actually has for their own, because obviously Anycubic makes their own resin as well, but the resins that they make are only good for models. They're not good for surgical guides. So because you're using a different brand of surgical guide, you're going to need to modify these settings within your printer. And this is very easy to do. And you can see you can take a screenshot of that, and this is going to be recorded, and we're going to upload it on our YouTube channel. So you can always pause it and look at this here, and you will be able to now go ahead and select your guide. and say, and just, use the settings that I'm giving you there, so that you know that your resin is going to be printed correctly within this printer. If you had a Sprint Ray 3D printer, probably you don't have to worry about this. But because we're combining two different brands, you do need these settings, and you do need to modify them within your printer. Now, I have this other equipment here, that this is a washer and a curing unit at the same time, made by Anycubic. I use this to wash all my guides, surgical and models, but I only use it to cure my models. In order for me to cure my Sprint Ray guides, I use the Sprint Ray curing unit, because again, you need a specific wavelength and time in order for this to cure correctly. So you're not going to be able to use this curing unit to cure that specific resin. So those are the things that you just need to keep in mind. But even having to purchase these other, either the resin and this additional curing unit, it still makes it less expensive than buying the whole Sprint Ray unit to do the whole thing. But again, nothing against Sprint Ray; they make great products. If you decide to go with their full system, that's great. I'm just sharing with you the way that I do it and the way that I've made it to manage. This is the guide that I printed for that patient, and you can see the guide. I'm using a acceptable resin for surgical guides. This can be used intraorally within the patient. This has now been fully cured, and this is that patient tooth number. You can see the guide sits beautifully on the cast, so I know that this guide is gonna sit perfectly in my patient's mouth, and I'm going to be able to use it to actually place my implant fully guided. And this is a BioHorizons implant that I chose for this patient, and you can see this is immediately after the surgical procedure was completed, with that same guide that I just shared with you. So the guide helped me, have full control of my surgical field, and I was able to do this guide myself in-house. So that would obviously reduce my cost. But this is the guide that was actually fabricated for me by Oral Arts. So this is the guide that they printed for me. And not only that they printed the guide for me, they give you a full list of, okay, this is the first drill that you're going to use. They give you a description of the steps that you should take for your surgical procedures, and at the same time, they were able to fabricate this nicely printed 3D printed custom healing abutments. So not only I was going to be able to use my guide to place my implants, but then I was going to be able to insert these custom healing abutments within the implants and get the correct emergence profile. All this was planned again from the get-go through that software. And now you can see this intraorally. These are my bleeding points. You can see my paralleling pins, and this is after my incision and a flap, and you can see the location of the implants right where we had planned. This is my completed osteotomies, my implants delivered within these sites, and there are my custom healing abutments. So I had all the tools I needed right there then for me to perform my surgical procedure, place my healing abutment, suture, and then go ahead, wait 4 months, make my final impression, send it back to Oral Arts, have them fabricate these screw-retained zirconia crowns. They are the crowns, fully seated, torqued, sealed, the access, and I was done with the case. Any questions you may have?